So good afternoon and welcome to our Learn and Share conference call. I'm Russ Derry, the Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is sleeping well with epilepsy, and we're pleased to have as our speaker Dr. Timothy Hoban, a pediatric epileptologist and sleep specialist from Michigan Medicine CS Mott Children's Hospital. So Dr. Hoban, can you briefly share your clinical and research interests and describe your experience with this topic?
Well, here at U of M, my clinical practice spans both general pediatric neurology as well as pediatric sleep medicine and pediatric epilepsy. And we certainly see lots of children who have problems both with respect to their sleep as well as with their epilepsy, and there's a lot of interrelationships that we'll be discussing today. Some of my research interests have included sleep-related epilepsies, the impact of vagus nerve stimulation on breathing during sleep, and electrical status epilepticus of sleep.
Okay, and we'll touch on several of those issues during the call. So thanks for joining us. So before we even talk about the complex relationship between sleep and epilepsy, let's start by talking about sleep in general and why it's important for everyone and what we can all do to get better sleep. So first, can you give a brief overview of how and why we sleep and what's going on in the brain and in the rest of the body at the various stages of sleep?
Well, it actually turns out that it's challenging to define what sleep actually is, because it was initially thought, say 100 years ago, that sleep was a very passive and inactive state. But we've learned a lot about sleep since then. It turns out there are a lot of important biologic processes going on in the body. That sleep's involved with hormonal regulation. It's involved with learning and consolidation of memory. But we still don't know for sure why we sleep. It does seem to be related to brain development. So we know that for mammalian species, sleep is necessary in mammals. That's not always the case with reptiles and other life forms. And we also know that sleep is necessary. So there have been animal models with rodents and things like that. It's been found that prolonged sleep deprivation is life-threatening. So it serves a necessary biological function. So we still have a partial understanding, but it's thought that sleep serves roles for physical rest and restoration. There's a thought that sleep may have served an evolutionary advantage, that, again, 10,000 years ago in a dangerous world, sleep would allow rest and restoration, but the ability to be awakened or alerted suddenly if there was a threatening change in the environment. What we know about sleep and some of the other biologic functions at this point in time is that sleep is very closely involved with certain aspects of hormonal regulation. So, for example, growth hormone secretion, which is important for growth for children, is very closely impacted very closely related to nighttime sleep. And even things like cortisol secretion, adrenal function, varies between day and night. A lot of the recent research for sleep and sleep disorders has also looked at the role that it plays in learning and memory. And again, it was initially thought that, well, maybe Rem sleep, dream sleep, would allow the brain to replay the body's memories to facilitate memory consolidation. But it turns out that it's a lot more complex than that. That rapid eye movement sleep, REM sleep, is part of what impacts memory consolidation, but other stages of sleep seem to play a complementary and necessary role as well. We also know that sleep is just not one state, that many people listening on this call may be familiar with REM sleep, rapid eye movement sleep, which is when dreaming occurs. That's about 20-25% of sleep time for older children and adults. And the remainder of sleep is what's called non-REM sleep, which is still necessary. We go through 90-minute cycles of deeper and lighter sleep during the night. So sleep has a predictable architecture. When we talk about other sleep disorders a little bit later on in the call, we'll also talk a little bit more about something called the circadian rhythm. And the circadian rhythm is the brain's internal sleep clock. So one way of looking at the circadian rhythm is that for a good sleeper, it's the circadian rhythm that helps a good sleeper fall asleep quickly at their normal bedtime, stay asleep through the night, and for some people, wake up in the morning at the same time without an alarm clock. That's the circadian rhythm doing its job, working for you to promote regular and good quality sleep. When the circadian rhythm is not working or out of alignment with the daytime schedule, these are things that can come into play with insomnia and other forms of disrupted sleep. And we know that people with epilepsy may be at greater risk for a variety of sleep problems, including problems with the circadian rhythm. So hopefully this gives a little bit of background.
Right. So bottom line, it's very complex. We still
right.
probably have
and we're
a
still
lot to learn, yeah. So more and more research is highlighting the crucial role of sleep in both health promotion and disease prevention. Can you talk about why getting enough quality sleep is so important?
Well, many times sleep is taken for granted, and some people I think have assumed that sleep is sometimes a luxury more than a necessity, so that sometimes if things are busy in their life that it might be possible to skimp on sleep. But we're learning more and more about the impact of disrupted and insufficient sleep, and it turns out that it actually has a lot of complicated impacts on how people feel and function in other ways. So again, there's been a lot of research on the impact of sleep deprivation on daytime alertness and learning, and those are things that are important to me as a pediatric neurologist and pediatric epilepsy specialist. That if a young person is not getting enough sleep at night, the daytime symptoms can impact attention, focus, emotional regulation, learning, and things that are really important that for a young person who's in school, and it has a big impact on daytime life. It's also found that insufficient sleep for both kids and adults can increase daytime tiredness, and this actually has lots of complicated and potentially serious ramifications. So there's a lot of literature that has confirmed that if somebody is driving drowsy, driving with insufficient sleep, it impacts reaction time. So even if a person is not at risk of falling asleep behind the wheel, there can be decreased reaction time, and there's evidence of increased rates of motor vehicle accidents. There's been some evidence that people who have chronically insufficient sleep seem to be more susceptible to infection. For both children and adults, there's also evidence that chronically insufficient sleep may be associated with increased risk for weight gain and obesity. And we understand a little bit of the chemistry behind this, insofar as insufficient sleep may cause the hormone cortisol to spike, which signals the body to store energy. The body stores energy as fat. And it's also thought that sleep deprivation can increase the so-called hunger hormone called ghrelin, which increases appetite. And it also decreases leptin, which inhibits hunger. And these things in combination may cause a person with chronically insufficient sleep to overeat and be at greater risk for weight gain. The impact of insufficient sleep also includes things like increased blood pressure. And there's interesting research in other areas, including things like impact on athletic performance, that people with insufficient sleep do worse so far as their athletic performance compared to people who are regularly getting sufficient sleep.
Right. So obviously it has a huge impact on health in numerous health-related domains. So what are the general guidelines regarding hours of sleep per night for the different age groups, and how can people accurately assess whether their sleep is sufficient?
Okay. Well, there are a couple of ways of trying to determine if a person's getting sufficient sleep. And keep in mind that individual sleep needs are highly individual. There's some people who are wiped out if they don't get 9 hours of sleep at night. But on occasion, there are people who can thrive on 7 hours of sleep at night. But we think that for most people, 7 hours of sleep is probably not enough. For those listening in on this conference, the National Sleep Foundation has a variety of information and tools that includes their recommendations for sufficient nighttime sleep. And so the National Sleep Foundation has issued guidelines that have generally suggested that for school-age children, the recommended amount is typically 9 to 11 hours of sleep. For teenagers, it's 8 to 10 hours of sleep, even though many teenagers don't get that much. And for young adults and adults, 7 to 9 hours of sleep is generally the recommended age. Another way that we look at sufficient sleep is that if a person can kind of look at their sleep patterns, if they have time off from work or time off from school or summer vacation or something like that, and if a person doesn't have to worry about what time they go to bed or what time they wake up in the morning for a period of time, the sleep patterns during that time help provide an estimate of the amount of sleep that a person kind of gravitates to if they don't have to be up at a certain time in the morning. And that can help a person estimate how much sleep their body does best on.
Okay. And does the hours of sleep does not necessarily equate to getting good quality sleep, right? How is there a way to determine whether you're, even if you seem to be getting enough hours of sleep, is there a way to determine whether it's good quality sleep?
Quantity of sleep doesn't always equate to quality of sleep, and that becomes especially complicated for people with epilepsy, where we know that people with epilepsy may be at greater risk for disturbed nighttime sleep, whether it's due to things like nighttime seizures or the impact of medications, or the fact that people with epilepsy may be more prone to daytime sleepiness independent of medication side effect, but just as part of their epilepsy. But, when we're working with patients and families in clinics, we try and look at indicators of sleep quality. So, for example, if a person is getting enough hours of sleep at night, but they're tired in the daytime, we may ask about symptoms like snoring or restlessness during sleep. That might be symptoms for sleep apnea, which is pretty common in both kids and adults. Or if somebody with nighttime sleep, if they have trouble getting their body comfortable at bedtime, and if they have leg jerks during nighttime sleep, we screen for things like restless leg syndrome. So we try and be watchful for symptoms of disturbed sleep, because that can be a red flag that there might be something going on disturbing sleep quality, and a lot of these conditions are treatable.
Okay, great. So what are some of the most important steps that all people can take to improve their sleep?
Well, we think there are a variety of things that help promote healthy, good quality sleep and sleep that regularly meets a person's needs so far as the amount of sleep. So we use the general term of sleep hygiene to talk about these different practices. And again, the goal is just to ensure that a person is getting enough sleep on a regular basis to be at their best in the daytime. So we think that some of the things that help promote good sleep hygiene, one is to try and keep a regular sleep schedule. And part of the reason for that is that it helps get the circadian rhythm working for you. So, for example, if a person has the same bedtime and roughly the same wake-up time in the morning 7 days a week, that helps strengthen the circadian rhythm to help a person fall asleep and stay asleep at night, get good quality sleep. Whereas if a person has a widely variable bedtime, where maybe they go to sleep at 10 p.m. on weeknights, but on the weekends they stay up until 2 or 3 and then sleep in, if the sleep schedule's irregular, it kind of weakens the circadian rhythm, and that can result in suboptimal sleep quality down the line. And again, people have different levels of tolerance for variability in sleep schedule, but we think that if a person has a sleep problem, keeping a regular schedule is one of the things that can help. We also try and look at things like good bedtime habits. And, we know that certain things can impact how long a person sleeps. So there's been a lot of interesting research on things like use of electronic devices at bedtime, whether it's watching TV, watching Netflix, being on a tablet or a computer or portable phone. And what's been found, and I'm more familiar with this research in teenagers compared to adults, but what's been found is that use of electronics and screens at bedtime can disrupt sleep in a couple of ways. One is that these activities often wake up the brain a bit. So a person might feel that watching something at bedtime helps the brain settle. But when they've actually done medical studies, it turns out it often keeps people up later and cuts into their sleep time. The other thing is that the light exposure at bedtime also can activate the brain a little bit. And that's something that can shift the circadian rhythm a little bit later and can sometimes play a role in insomnia. We also know that a number of other lifestyle habits come into play. So, for example, in the adult population, we find that consumption of alcohol near bedtime may help a person fall asleep faster, but it actually negatively impacts sleep later on in the night. So alcohol near bedtime can help a person fall asleep faster, but they may get lesser quality sleep later on in the night or may be more prone to waking up later in the night. So again, for people with sleep problems in particular, we recommend trying to shy away from alcohol near bedtime. Caffeinated beverages and medication side effects also come into play. And again, if a person has problems with insomnia or sleep quality or not getting enough sleep, we generally recommend trying to shy away from caffeinated beverages after about 4 p.m. or so. Another thing that comes into play with sleep habits and sleep hygiene is daytime napping. And again, that can also be a little bit more complicated area for people with epilepsy because if a person's had a seizure, sometimes it's necessary and appropriate to sleep after the seizure while they're recovering. But we also know that daytime napping sometimes makes it more difficult to fall asleep at night. So again, there are times when naps can't be avoided if a person's sick or if the person had a seizure. But at the same time, we try and, if a person has a sleep problem, we try and discourage unnecessary napping, voluntary napping, because that does sometimes cut into nighttime sleep duration. And we think, in general, the quality of sleep is higher trying to do most of all of your sleeping at night compared to getting some of your sleep in a daytime nap and a smaller amount of sleep at night. So those are some of the things that come into play with sleep habits.
Okay, great. And I've heard that if you are to nap, if you need a nap, or if you're voluntarily choosing to have a nap, that at least if you can keep it less than half an hour or less, that it's less likely to disrupt sleep. Is that true?
Yes, that's the general rule of thumb, is that if there is a need for a nap, an elective nap, trying to keep it shorter on the order of 20 or 30 minutes is short enough to be refreshing for many people, but a person will tend not to go into deeper sleep that would have a more substantial impact.
Okay, great. And in terms of screen time, because as someone with teenagers, it's obviously a hard habit for them to break. But how many hours or how much time prior to sleep would you recommend having screens off?
Well, we think for a lot of people it's valuable to try and back off on stimulating activities for at least 30 to 60 minutes before going to sleep, because that allows the brain a little bit of transition time from activities where your brain may be engaged and more active to maybe try and shift gears and do something a little bit quieter that may make it easier for a person who's drowsy to fall asleep at those times. It also depends on the person's constitution and whether or not there's a significant sleep problem. And that's one area where people can be dramatically different. There are some people whose sleep habits might not be the greatest, but they still fall asleep quickly and get enough sleep. But at the same time, if a person's not getting enough sleep, then we think it's valuable to try and do the things that give you enough sleep at night and better quality sleep. And so we certainly find that, so for example, in my practice, I deal with teenagers, and one of the big concerns is that most teenagers do not get sufficient sleep. The National Sleep Foundation did an assessment of teenage sleep habits a few years back, and they found that only 20% of teenagers regularly got sufficient nighttime sleep. And I think it was about 30% of teenagers where it was a borderline amount, and nearly half of teenagers did not get sufficient sleep on a regular basis. And so because insufficient sleep is so common in teenagers, we think that trying to move screen time earlier is one of the things that can help them get a little bit more sleep. We also recognize cell phones are ubiquitous, and there's lots to do, and there can sometimes be some challenges in trying to implement that at home.
Right, and there's certainly some environmental barriers to getting enough sleep for teens as well. With high schools, start times usually very early, and then also if you're doing any kind of sports or extracurricular activities, with homework loads, you may be up till 10 or 11 o'clock sometimes just to get your homework done. So it can be challenging, certainly.
Yeah, no, and you point out some of the really pertinent examples for things like that. So, for example, if a young person's working hard trying to complete their homework, but it's their homework keeping them up to 11 at night, that's a really challenging set of circumstances to change sometimes.
Right. Okay, so now let's talk about how sleep and epilepsy are related. So we know that sleep deprivation is a common trigger for seizures. Does sleep deprivation typically act as an immediate trigger, or can it sometimes have a delayed or cumulative effect? Can you talk a little bit more about that?
Mm-hmm. Well, I think the short answer is that both acute sleep deprivation and chronic sleep deprivation can probably represent a trigger for at least some individuals with epilepsy. And again, this is also an area where we have a partial understanding, and the reason for that is that different sorts of epilepsy respond differently to sleep deprivation. So there are certainly several types of epilepsy where we know that sleep deprivation can be a very, very consistent trigger. Probably the classic one is juvenile myoclonic epilepsy, where we know that individuals with condition can be extremely sensitive to sleep deprivation as a trigger for seizures. They also have sleep-wake influence seizures in the form of myoclonic jerks in the morning time, often after morning waking. Another variety of sleep-related epilepsy includes benign Rolandic epilepsy. But then even people with other types of epilepsy, sometimes sleep deprivation can be a trigger. So in our neurology clinic, we sometimes see children who had their first seizure, during or following a sleepover, when there was significant sleep deprivation at play, and that was their very, very first seizure of life. Neurologists for years have recommended sleep-deprived EEGs, and the reason we do that is that it enhances the sensitivity of the EEG test for things that might not otherwise be obvious. So even if a person doesn't have nocturnal seizures, it's thought that if a person's sleep-deprived, that may bring out intermittent EEG abnormalities like spikes and sharp waves and things like that, even between the seizures, and that the sleep deprivation may make the EEG a little bit more sensitive to see what parts of the brain are electrically irritable. We do have a lot less data so far as the impact of chronic sleep deprivation, but at present we do think that chronic sleep deprivation is not a good thing, not just with respect to epilepsy, but with respect to daytime function, alertness, and accident risk. But we think that some individuals with chronic sleep deprivation are at risk of seizure exacerbations or increased seizure frequency relating to the insufficient sleep. Okay,
great. So you already alluded to some different types of epilepsy that feature seizures or other symptoms that are connected in some way to sleep. Can you talk about why seizures may be more likely to occur at different points in the sleep-wake cycle, and review some of the specific epilepsy syndromes that are connected to sleep? I know you already mentioned juvenile myoclonic epilepsy, but maybe talk about some of the others as well.
Yeah. So again, this is also one of those areas where it's fair to say that we have a partial understanding. So there's some research that suggests that synchronicity of brainwave activity on EEG influences seizure risk, meaning that times when the brainwaves are more synchronous throughout the brain, that is a time when seizure discharges may be more common or more easily propagated in a way which might be more prone to cause seizures. The synchrony of EEG activity actually changes pretty substantially between wakefulness and sleep. The wakefulness is described as a non-synchronized EEG state, but when a person falls asleep and goes into what's called non-REM sleep, the brainwaves do become more synchronous, and we do think that EEG discharges between seizures actually are more common during the early stages of non-REM sleep compared to wakefulness and REM sleep for many people. It's also thought that sleep-wake transition is a vulnerable time, meaning the times when you're first falling asleep at bedtime, the time when you wake up in the morning. But we also know in looking at normal sleep architecture, even a normal sleeper without a sleep problem, as you go through the night, get close to your morning waking time, people do have more arousals from sleep, and people have more in and out time of light sleep and brief wakefulness approaching morning waking. And so those tend to be vulnerable times for a lot of people with epilepsy, falling asleep late in the night around morning waking. But even with these influences, we know there's a lot of variability. There are individuals whose seizures are primarily daytime, primarily nighttime, sometimes a combination. And we have made progress in identifying some of the seizure disorders that are more closely sleep-related. So we already talked a little bit about juvenile myoclonic epilepsy, but benign Rolandic epilepsy, or more properly called benign epilepsy of childhood with centrotemporal spikes, is a condition where seizures are very commonly related to sleep, often when a child's falling asleep or waking up in the morning, and the seizures can range from focal motor seizures to generalized tonic-clonic seizures. A fascinating area of epilepsy when it comes to the relationship between epilepsy and sleep is frontal lobe epilepsy. And as many of the people participating in this call are probably aware, frontal lobe seizures don't always follow the regular rules so far as what seizures look like and how seizures behave. The frontal lobe seizures sometimes cause very unusual behaviors that may not look obviously like a seizure. Can include repetitive movements or running or agitation. And when frontal lobe seizures arise from nighttime sleep, it can sometimes be very, very hard to tell the difference between a frontal lobe seizure and sleep disorders like sleepwalking or night terrors or things like that. And we know that frontal lobe epilepsies are often a type of epilepsy that will tend to occur primarily or exclusively during nighttime sleep. And so that's a little bit of a red flag that if a person presents with unusual behaviors at night, sometimes it takes a little bit of time and investigation to determine, okay, is it a sleep disorder like sleepwalking or night terror, or could this actually be something like a frontal lobe seizure, which would be treated much, much differently? A final area of epilepsy that relates to sleep that we, again, still have a lot to learn about is electrical status epilepticus of sleep, or what's been called continuous spike wave of sleep. And this is a condition where individuals typically will not have clinical seizures during sleep. But if you're running an EEG at night, we'll find that the majority of their EEG activity during deep nighttime sleep is comprised of spike wave activity. And even though they're not having clinical seizures, this background activity seems to disturb sleep quality in a way that carries over and affects how people feel and function in the daytime. And the daytime symptoms are pretty variable, and again, we're still learning about it, but it ranges from things like autism-like regression to language or learning or behavioral problems. And again, one of the challenges with electrical status epilepticus of sleep is that you don't see visible signs that clue you in that there's a problem at nighttime. You can only see it electrically on an EEG or on a sleep study during nighttime sleep. And And again, most people who get EEGs get daytime EEGs, so you're not even recording. Many times EEGs are recording daytime brain activity and not nighttime activity when these conditions occur.
Right. So that certainly points to the value of long-term video EEG monitoring to detect these types of conditions that might otherwise be overlooked.
Yeah, and that's one of the things that as neurologists and other healthcare practitioners, working with individuals who have epilepsy, we try to be sensitive to. If we see an abrupt change in daytime function, there's not an obvious explanation, then one of the things we think about is, could there be this electrical status epilepticus? Do we need to be considering an overnight portable or video EEG study to screen for that?
Right. Okay. So nocturnal seizures, particularly nocturnal generalized tonic-clonic seizures, and sleeping in a prone position, on your belly, are both possible risk factors for SUDEP, or sudden unexpected death in epilepsy. Additionally, many cases of SUDEP occur during sleep. So can you talk briefly about SUDEP and its association with sleep and possible ways to reduce one's risk for SUDEP?
Yeah, SUDEP is such a challenging topic on so many levels because it's, as the name implies, it's sudden, it's unexpected, there's no advanced warning. And it's also something that I think is challenging for neurologists and healthcare professionals, as well as patients and their families, to sometimes discuss, because it can be kind of a stressful conversation where sometimes we still have more questions than answers, unfortunately. But I think the reason why it is important to discuss it and be aware of it is that it does happen. That the Epilepsy Foundation estimates, are for a prevalence of about 1 in 1,000 adults and 1 in 4,500 children with epilepsy. And again, in many instances when SUDEP occurs, it often occurs during nighttime sleep. There may or may not be evidence that a seizure had occurred at the time. And individuals are often found laying face down, but it's still unclear, is that playing a role in the death or not. So for right now, we have not found a good, reliable way to identify who is at greatest risk for SUDEP. And what we try and do is we think it's important to try and treat a person's underlying epilepsy as completely and effectively as possible. But we also try and identify other risk factors that might be controllable. And so, for example, if a person has an underlying sleep disorder, if a person has symptoms of sleep apnea, the concern is, well, if the person has a breathing problem during sleep plus epilepsy, those may be multiple things that could increase a person's risk. So that we do try and identify which people actually have sleep disorders, things like sleep apnea, because that's something that's treatable. And we sometimes try and screen for other medical conditions that might impact risk of unexpected events, like irregular heart rhythms or things like that. We can sometimes do testing of heart rhythms or get a cardiologist referral to try and be sure that we've screened for other medical conditions that might impact a person's risk.
And in terms of reducing risk, I know a lot of particularly caregivers ask about devices like mattress-based seizure alert devices or seizure watches that will detect and alert caregivers to a seizure. As far as I know, there's no evidence to suggest that those can actually reduce the risk of SUDEP, but is there at least a rationale for using such devices to possibly intervene if a seizure is detected?
Yeah, I don't think we have enough good evidence at present to know how sensitive these different devices are for conditions like SUDEP. As most of the individuals participating in the call are aware, there are a variety of devices that have been used for monitoring, including mattress monitors, other movement monitors. More recently, there have been things like the Embrace Watch, which tries to monitor both movement as well as heart rhythm changes to try and identify seizures. There are other monitors, including things like seizure dogs and things like that. Again, there's kind of limited formal medical research for a lot of these devices. Some of the research out there suggests that, these devices may represent an aid in detecting nighttime seizures, but it's thought that the sensitivity would probably be greatest for convulsive seizures, grand mal seizures, as opposed to things like complex partial seizures, where there might not be as much movement or changes in heart rate. Again, because it's not completely certain whether SUDEP necessarily involves a seizure, there's no guarantee that these devices might be sensitive to SUDEP if what's going on affects more heart or breathing or things like that, rather than movement.
Right. Okay.
The other issue that comes into play is that many of these devices have a pretty high rate of false alarms, and that's the other angle I think that's appropriate for families and medical practitioners to think carefully about before deciding does it make sense to use a device like that, because many of the studies that have looked at these devices show pretty good success rates, pretty good sensitivity rates in detecting convulsive seizures, but they also show pretty high rates of false alarms. So if you're getting false alarms pretty frequently at night, that can secondarily cause problems and disrupt sleep quality.
That's a really good point, yeah. Okay, so people with epilepsy are at increased risk for sleep disorders. You alluded to that. Can you talk about some of these specific disorders and treatments that are available for them?
Sure. So I think starting with things that are common in the general population, sleep apnea is one of the things that we to have on the radar screen for both medical practitioners and families because it's so common. It's estimated that probably up to 7% of adult men have sleep apnea with daytime sleepiness. The prevalence in adult women is thought to be 2 to 5%. The risk of sleep apnea for adults increases as people get older. It increases for women after menopause. But even in the pediatric population, sleep apnea is relatively common. It's about 2 or 3% of children have obstructive sleep apnea. And so because sleep apnea can disturb sleep quality, and we think that it might secondarily impact seizure control for at least some people, it's one of the things that it's important to have on the radar screen, to just have people be watchful for symptoms like snoring and mouth breathing and restlessness and sweating during the night, because sleep apnea can be diagnosed pretty easily on a sleep study, and there are a variety of different treatments for both children and adults with obstructive sleep apnea, depending on the type and the severity of the problem. Another area that we look a bit more carefully at is that we know that certain epilepsy treatments can impact nighttime sleep. So, for example, certain seizure medications might predispose to insomnia, whereas others might be causing daytime tiredness and sleepiness. We also know that for people with epilepsy treated with a vagus nerve stimulator, that the vagus nerve stimulator might be associated with increased risk for sleep apnea when their stimulator cycles during the night. And so these are things that we will consider screening for with people being implanted with a vagus nerve stimulator. Another way that people with epilepsy are at risk is that just the underlying seizure disorder, independent of the medications, can have a substantial impact on sleep. So if a person has sleep-related seizures, that can disturb sleep duration and sleep quality. Some people may wake up for a while after their seizures, which may further disturb their sleep. And then if a person's recovering from their seizure, whether it occurred at nighttime or daytime, that may result in an increased need for daytime napping that's hard to avoid. And all of these things can impact the amount of sleep and the regularity of sleep and kind of secondarily disturb sleep quality. So those are things we try and be watchful for on the sleep side for people with seizures.
Right. Okay. So several sleep disorders can actually be confused with epilepsy, things like night terrors or parasomnias and things like that. Can you talk briefly about these and how to distinguish them from epilepsy?
So yeah, I think we'd already briefly touched base on the fact that frontal lobe seizures arising from sleep don't follow the usual rules. That they're often not convulsive seizures, but it might involve agitation or running or movements or behaviors that might not be immediately obvious as seizures. And some of these behaviors can sometimes mimic things like sleepwalking or night terrors. Sleepwalking and night terrors have a much different basis. Those are episodes of partial waking up from very deep sleep, where a person is awake enough to be agitated or screaming or running around or walking around with sleepwalking, but usually not awake enough to be fully responsive or remember it the next day. Now, there are a couple ways that we can try and help distinguish between sleep disorders and frontal lobe seizures. So, for example, things like night terrors tend to be most common in preschool and early school-age children, and they tend to become less common as you get older and into adulthood. So if somebody suddenly develops what looks like a night terror, but they're much older and they didn't have a history of it, you get a little bit more concerned. Okay, maybe we need to screen for seizures. Frontal lobe seizures arising from sleep typically tend to develop in a little bit older children or adults. And then one of the big distinguishing features is that most people who have sleepwalking or night terrors, those only usually occur on an occasional basis, whereas many people with frontal lobe epilepsy will have the same sort of event happening multiple times per night. And again, that's also a big red flag to look a little bit closer to screen for seizure-related causes. If it's multiple times per night, most nights, it's less common for the sleep disorders to cause that. The other way we look at things, and again, sometimes families, if there's a family member or bed partner available, sometimes families can obtain a video recording at home, to take to their neurologist or medical provider, and just looking at the nature of the movements can sometimes help distinguish, is it more likely to be a sleep disorder like a night terror or something like a frontal lobe seizure. Unfortunately, though, there are some times where we simply can't tell just on the basis of what the event looks like on a video. And in cases like that, doing a video EEG study or a sleep study with video EEG sometimes provides better clarity so far as the nature of what's going on.
Okay. And can you talk a little bit more about that, about the relative roles of sleep studies and video EEG monitoring in diagnosing sleep disorders and nocturnal seizures? And is there ever a situation where you can do kind of a hybrid sleep study and video EEG monitoring at the same time?
We can sometimes do hybrid testing, but there are some inherent trade-offs with both modes of investigation. So again, when we're trying to determine what is causing the nighttime spell, at minimum, you really need a good quality EEG and good quality video to be able to distinguish between the major possibilities. Inpatient video EEG monitoring in general provides the best quality EEG, the greatest variety of EEG tools to sort through artifact and to be able to detect even subtle seizures, and usually the best quality video. But the limitation is that it doesn't give you the information about other things that affect sleep, like breathing or limb movements, like you can see associated with restless leg syndrome or things like that. a nighttime sleep study, the standard sleep study is very sensitive to things like sleep apnea, which can be a trigger for sleepwalking and night terrors, or for excessive limb movements, which can occur in people with restless leg syndrome. But the standard sleep study has only a little bit of EEG monitoring because you use that to determine is a person awake or asleep, and if a breathing disturbance happens, does it disturb the normal flow in deeper and later sleep. At our institution, we can do an expanded EEG as part of a sleep study, but it still is not quite as sensitive as the study done in the EEG lab. We have fewer tools to assist us in detecting seizures and addressing artifact and things like that. And the video quality is not always quite as sensitive. So in determining which of these two types of tests is the best for the circumstance, it sometimes depends what you're most suspicious for. If you're really most suspicious for a seizure and a person doesn't have risk factors for sleep apnea like heavy snoring or restlessness, then many times the video EEG might be the best test to try and look at the event. Whereas if it's thought that a person has snoring and other risk factors for a sleep disorder, and the behavior seems more suspicious for a night terror rather than a seizure, then maybe the sleep study with the expanded EEG is the better test because you get a lot more sensitivity for breathing and the other sleep side of things.
Right. Makes sense. Okay, so in terms of nocturnal seizures, how important is it to try and track these seizures if they're occurring during sleep? And is there a reasonable way for family members to do this, without completely disrupting their own sleep schedule and causing a lot of stress? And then also, how do adults with epilepsy who live or sleep alone track their nocturnal seizures? The value of detailed logging of nighttime seizures really depends on the circumstances. Right. And so if somebody has occasional seizures, just a regular daily seizure calendar is actually pretty good. But say maybe a person is just beginning treatment for primarily sleep-related seizures. And sometimes if you're just starting treatment or you're changing treatment and you're trying to decide if you make progress, well, that's an area where sometimes keeping a more detailed log can give you guidance so far as whether or not you're making progress. And especially if somebody has multiple seizures or multiple events per night, if you're not maintaining your log of calendar of some type, sometimes it's tough to think back, a week ago, was it 2 or was it 5 events that night? And so there are times, especially if you're just starting or if you're adjusting treatment for somebody with nocturnal seizures, that it can be helpful to track more closely. As a general rule, I will recommend that families try and do their seizure log first thing in the morning after a person wakes up while everything's fresh in mind, and they try and do a summary of just what happened the previous night while it's fresh in mind. I think it's a little bit more challenging to ask a person or a family to do the log on the fly at night because, again, if there's a seizure, a person may not be at their best. Just putting something on a log may keep a person awake for longer than they have to be. And again, we try not to make this a burdensome chore or to cause unnecessary sleep disruption. There are also some tools that aid in the process. There are smartphone apps that can aid with logging seizures, or some of them will even allow a video of a seizure at night. And those are things that families can take a look at available apps and see if there's something that might be a fit for their particular needs. Right. Are there any circumstances under which people who have exclusively nocturnal seizures, any situations in which they should be allowed to drive?
That's such a tough question because
you don't have to answer because I don't want to put you on the spot. So, but
no. I think tough questions. It still is important to think about the elements of the decision making. Right. There are certainly people who have seizures primarily or exclusively at night, and that is so challenging when it comes to issues like driving. Some of the decision-making is actually out of the hands of medical providers and families, because we have laws that vary state by state that have a pretty big impact on those decisions. So again, as many people on this call are probably aware, the state law in Michigan is that a person cannot drive for a period of 6 months following a seizure or other alteration of consciousness. And the state law doesn't really specify any exceptions. But laws vary substantially state by state. And my understanding, for example, in Ohio, I don't think there's a specific duration recommendation of seizure control that the state mandates, although there is some mandatory reporting and sometimes some investigation and use of a provisional license. In addition to the legal aspects and guidelines and things like that, there's also just the issue of trying to assess the relative likelihood of a seizure while driving and the degree of safety risk. And again, people will argue different sides of this, but I think everybody keeps in mind people are trying to operate from the standpoint of safety. And as somebody who's worked with families where a person patients have had seizures while driving, we take the safety aspect very seriously. And that's where it's most complicated. If a person has primarily nighttime seizures but occasional daytime seizures, it's hard to know what the exact risk is. Right. And people have different views of how to address that risk.
Right. Okay. Again, we alluded to this a little bit, but can you talk a little bit more about how anti-seizure medications can affect sleep?
The impact of medicines on sleep is different for different medications. There are probably different degrees of individual vulnerability and sensitivity. But I think the things to keep in mind is that you look for patterns. So if somebody is starting a new medication or changing medication, and it's right then that they begin to have insomnia at nighttime sleep, then there's a pretty good chance the medicine is playing a role if nothing else has changed. All seizure medicines carry some potential for daytime tiredness. And again, a person's individual tolerance may be variable. And there are many people where a standard dose or standard blood level of seizure medicine may still be associated with tiredness. We also look at, if we do sleep studies and EEGs, we can also look a little bit more precisely at the impact of seizure medicines in nighttime sleep. And so it is thought that at least some seizure medicines can alter sleep architecture, the flow of deeper and lighter REM sleep and non-REM sleep. And it seems to be REM sleep, dream sleep, that is more vulnerable for most seizure medications. But it's not like there's one medicine that's head and shoulders better or worse than another. And again, there's not a seizure medicine that would be completely free of risk of impacting nighttime sleep. So you really need to look at sleep quality and sleep duration at the same time that you look at the other risks and benefits of treatment with seizure medications.
Right. So in terms of other treatments for epilepsy, are there any unique ways in which epilepsy surgery, VNS, RNS, or the ketogenic diet can affect sleep? Well, we have very, very limited formal research in those areas, with the exception of VNS, which we have more detailed data. Probably about 15 years ago, I think it was, there were the first reports of obstructive sleep apnea in individuals with vagus nerve stimulation. And we've had subsequent reports of sleep apnea in children with vagus nerve stimulation. And not everybody gets it. Some people who do get it actually have pre-existing predispositions to sleep apnea. And at present, if we're considering
using a VNS, we will often check a sleep study to see how breathing is doing and screen for sleep apnea, both before implanting the VNS and then after the unit has been placed and time has been taken to reach the target parameters. We will often recheck breathing. Sleep apnea in people with the VNS, the apneas sometimes coincide when the unit is actually stimulating the vagus nerve. That's the same time that individuals with the VNS may notice hoarseness of the voice or tickle in the throat or things like that. And the sleep apnea is not always at a point that needs treatment. And there's some evidence that suggests that changing the frequency of the electrical impulse, lower frequency settings, may be less apt to cause sleep apnea compared to higher frequency settings. So sometimes the neurologist or medical practitioner might have a little bit of leeway to adjust the current settings, to do other programming adjustments to see if that helps breathing. We really don't have a lot of good formal data so far as impact of things like epilepsy surgery or ketogenic diet or RNS, specifically as regards sleep.
Okay. Can you talk about the risks and benefits of sleep medications and sleep supplements for people with epilepsy?
Well, because sleep, disorders are common in people with epilepsy, we do often need to look at, the impact of other potential treatments. We do urge, as a general rule, caution with using medications like Ambien and Lunesta for a couple of reasons. One is that the side effects can be additive with many seizure medications, and that's something where a person might be more sensitive to daytime tiredness or sleepwalking or other sleep eating or other unusual behaviors at night if they're also taking seizure medicines in addition to something like Lunesta or Ambien compared to somebody who's not taking seizure medications. The other area where we urge caution is that medicines like Lunesta and Ambien tend to be most effective for treatment of short-term insomnia, but they tend to be a lot less effective, or they tend to lose effectiveness, actually, if you use them for long periods of time. And so if a person has a chronic problem with insomnia, we think that it's important to look for other medical causes where there might be more effective treatments available. We also find, in addition to prescription medications, certainly melatonin is one of the most widely used supplements. And the reason for that is that melatonin is one of the chemicals that the brain uses to signal readiness for sleep. And it's thought that giving small doses of melatonin before bedtime can help people fall asleep faster. It certainly is not a cure-all. In our sleep clinic, we'll tell families that for most people, melatonin is more of a gentle nudge towards sleep as opposed to a strong sedative. But it is one of the agents that can be helpful. We think it's relatively safe. And of all the medicines that have been used for treating pediatric insomnia, which is my area, there's much more research regarding the impact of melatonin compared to use of prescription medications. Finally, I think the other area to look at is that insomnia can sometimes be a symptom of another problem. So it's very important to look kind of carefully for other medical influences for the insomnia that would be treated differently than just taking an added sleep medicine. So, for example, restless leg syndrome is thought to affect 5 to 10% of the adult population. And unless you ask a person, are you having trouble getting comfortable at bedtime? Do your legs bother you? Do you have kicking movements during nighttime sleep, or does your bed partner notice that? Restless leg syndrome and periodic limb movement disorder can be part of insomnia, but there's some pretty good treatments available if that's one of the major influences. People with sleep apnea, sometimes their breathing disturbance occurs right when they're drowsy and falling asleep, so they're getting drowsy on the verge of falling asleep, but then there's a problem with breathing that wakes them up. So sometimes sleep apnea is part of the picture for insomnia. If there are behavioral factors for insomnia, if a person is dealing with anxiety, if they have a lot on their mind for school or work or things like that. There's actually evidence that suggests that maybe behavioral treatments might be preferable to medication treatments long term if that's a big part of what's factoring in. So you have to kind of carefully look at what's causing insomnia, because so many different things factor into it, and where to focus the effort really depends on what the precise influences are.
Right. So when you mention behavioral treatments, is that referring to things like cognitive behavioral therapy for insomnia? And is that something that basically if someone's insomnia appears to be related to worrying or anxiety related, or just having difficulty slowing down the brain and your thoughts, is that a recommended treatment in that case?
Yeah, that it really is one of the more studied and validated and recommended treatments under those circumstances, because it really kind of maximizes the non-medication interventions. And CBTI includes a combination of different approaches that can include some degree of sleep tracking, education, work on sleep habits and such. And again, many times there can be cognitive techniques that can be used to help a person whose brain is still too active at bedtime reach a point where they can fall asleep more commonly. In the same vein, if a person has more significant anxiety or depression or things like that, sometimes insomnia is one facet of that, and it's important to recognize if there's a mood disturbance or anxiety as part of what's going on. It's important to try and investigate that and try and find the appropriate level of treatment.
Right. Okay. And lastly, daytime drowsiness can be a common symptom in people with epilepsy, and that may be related to poor sleep, or it may be medication side effects. So how can people determine the relative role of these two factors in causing their daytime sleepiness?
Daytime sleepiness for people with epilepsy is so common, and I think it's really under-recognized. And I think it's so important that be on the radar screen for both patients and medical providers, because many times we have tools that may not cure it, but may at minimum provide some help. So daytime sleepiness for people with epilepsy, it's usually not just one cause. It's usually a combination of causes. And we think the likely elements for many people, one is that we do suspect that people with epilepsy tend to be sleepier in the daytime than people without epilepsy, irrespective of medication side effect. But on top of that, medication side effect is often part of the picture. Comorbid sleep disorders, including things like sleep apnea, restless leg syndrome, behaviorally insufficient nighttime sleep, that's also part of it. Irregular sleep habits can be part of it. But then part of it relates to the nature of the epilepsy, that if a person's dealing with breakthrough seizures, that can disturb sleep quality and continuity or necessitate some daytime napping and things like that. And those are things that are a bit tougher to control. So the way we try and address these things is by looking carefully for treatable underlying elements. If somebody has sleep apnea, it's important to recognize it, try and treat it. If a person seems to be sensitive to medication side effects, then it's important to try and use the least amount of medicine necessary, or sometimes it's appropriate to try different medicines to try and find out what causes the least problem with daytime tiredness. Just looking at sleep habits and sleep duration. If the sleep habits are not optimal, that's an opportunity for intervention. And in general, a person who is habitually getting the amount of sleep that their body does best on, they're less likely to have daytime tiredness than somebody who's cutting it a little bit short so far as sleep duration. And then finally, if somebody is still persistently sleepy despite doing all those other things, there are occasions where we will sometimes use medications to treat daytime sleepiness, but at the same time, we try and use those carefully, and only after exhausting all appropriate non-medication treatments do we reach the point of considering adding on another medicine to combat daytime sleepiness. But the thing is, daytime sleepiness is not a good thing. not good if a person is working. It's not good if a person is in school trying to learn. It certainly impacts things like accident risk and occupational safety risk. And so it's important to be watchful as part of regular neurologic and epilepsy care to try and keep an eye on that and do these things to try and keep it under the best control possible.
Right. Okay, great. So before we open it up to questions, do you have any closing thoughts on this topic you'd like to share?
Wow. I think with that last question about the daytime sleepiness and things like that, that was the main thing I wanted to be sure that we talked about. But no, I don't think I have anything else.
Okay, great. Well, I'm going to go ahead and unmute the lines. Okay, who'd like to get us started with a question?
Hi, I'm Marissa Morgan, and you had just made a comment about the daytime sleepiness. I take Dilantin, and when I first started taking Dilantin many years ago, my neurologist had me to take it 200 milligrams in the morning and 2 at night. And I found that the Dilantin was making me so drowsy during the day when I would take it. And I work as well. And so I had to go back and tell my neurologist that I have to just take it in the evening time. So I have a set time that I take my Dilantin between the hours of 6 and 7. And then by the 10 o'clock hour, I'm feeling that drowsiness. So I had to, let go of taking that during the daytime because I was getting too sleepy and I wasn't being as productive as I was supposed to be.
All right. And I think you bring up a good point there, Marissa, about, the importance of talking with your neurologist about any issues with daytime sleepiness because adjustments can be made just like you described. So, Dr. Hoban, anything to add?
There are times when somebody can get by with just an evening time dose, but it's important to work with your neurologist or medical provider to try and find the best balance. Because sometimes if a person's just taking an evening dose, the blood levels of a seizure medicine, there's greater variability throughout the day, and for some people that may not have an impact. Other people may be sensitive. So it's just important to work with a neurologist to try and find the right schedule, the right dose, and in some cases the right medication to reduce sleepiness to the extent possible.
Okay.
Other questions?
I have a question.
Go ahead.
My name is Jillian Jones, and my son is 4, and I was curious on possible recommendation on a sleeping device, sleep monitor for a 4-year-old that has Deuce syndrome.
Did you say Deuce syndrome?
Yes, Deuce syndrome.
Mm-hmm. Okay. So that's something where I would recommend that you schedule a time to speak with your child's neurologist to kind of go to discuss the available options and the trade-offs and limitations. So again, for children, if there's concern about nighttime seizures, we look at things a couple of ways. If there's concern that there might be a medical sleep disorder, there are times it's appropriate to do a nighttime sleep study, not just a nighttime EEG, but looking at breathing and other things to see are there any risk factors or any other medical influences with nighttime sleep that might need to be treated differently. The other reason why it's important to talk with your neurologist who's most familiar with the specifics of what's going on is that all of the available devices have trade-offs and limitations. There's not a perfect device out there, unfortunately. Some of the devices are sensitive for convulsive seizures, but have a lot of false alarms, and that can disturb sleep quality. You need to think about those trade-offs before doing that. There are also cases where if a child has non-convulsive seizures, a mattress monitor or some of the available monitors may not provide as good sensitivity in picking those things up. And that's where specifically sitting down with the neurologist and discussing the trade-offs at length is so important in deciding is that something that's appropriate for you and your family.
Okay, thank you. I agree. It's hard when he sleeps with us, so that's why I went on for this. Is he sleeps with us, and it of course disturbs all of our sleep, but
right.
You never know when a seizure is going to come, so it kind of feels like the best route.
No,
thank you.
No, and that's so true. For many families who have a child with nighttime seizures, it's pretty common for children to sleep with or close by their parents because that does provide closer monitoring, but that has its trade-offs too, because it means more arousals and more sleep disruption. So even that approach, it ensures safety, but it's not perfect.
In terms of cases where maybe a child has a coexisting disorder that can affect breathing and heart rate and maybe put the child at increased risk for aspiration and if there's additional risk factors for sleep-related injury or death, are there cases where things like sleep apnea monitors or heart rate monitors or breathing monitors or things like that, or pulse oximeters, more advanced medical devices would ever be worthwhile?
Well, even nighttime monitoring for primary sleep disorders like sleep apnea are pretty limited. So for example, pulse oximeters have the advantage of being, pretty widely available and non-invasive, but it averages the signal, and it may miss brief dips in blood oxygen levels, so it could certainly miss a seizure, or it could miss non-convulsive seizures where oxygen is not immediately impacted. And again, if the unit has an alarm, then if the lead comes off or if a child or a patient wiggles out from the monitor, that can also cause secondary sleep disruption. Same thing applies with other cardiorespiratory monitors and heart monitors and things like that, is that they have varying degrees of sensitivity. An oximeter will provide screening for a substantial prolonged dip in blood oxygen levels. But at the same time, the cost is, if the sensor comes off, it may require a lot of effort to wake up at night, put it back in place, and that many of the available devices have very frequent false alarms, which can also impact sleep quality as part of that. So things really need to be tailored to individual circumstances. If somebody has a severe problem or high risk, then sometimes those are acceptable trade-offs. Where if somebody is relatively low risk or has well-controlled seizures, then maybe the side effects of the monitors sometimes outweigh the benefits.
Right. Okay, great. Other questions?
I have one question. My name is Melissa. My 4-year-old has had sleep issues for a long time. In fact, we see you, Dr. Hoban, at U of M. And we just discovered through Beaumont this summer that he has a 50% spike in wave ratio for his sleep. How often should we be monitoring the spikes and waves if it's just at the beginning of treatment, because it's clearly impacting his sleep and his development? So we're just not sure, as new parents to this whole thing, how often do you monitor this stuff? And if sleep is so important, that's just our concern.
Okay. That still is in a little bit of a gray area. So again, for those not familiar with this, the electrical status epilepticus of sleep is a condition where there are frequent electrical discharges during nighttime sleep that do not cause obvious clinical seizures but can disturb sleep quality. Traditionally, we have diagnosed electrical status epilepticus of sleep when the frequency of spikes exceeded 85%. That's the classic cutoff for diagnosis. It has since been recognized that some children may have symptoms with less frequent discharges. But this is also an area that is challenging for both us medical types and families because there seems to be some variability. Not everybody is affected the same way, and it sometimes takes time to determine whether giving medications to reduce the frequency of this activity is it really associated with clear improvements, both on the nighttime EEG, but also how a child feels and functions in the daytime. There's not a standard set of protocols that are used. There's a lot of variability from institution to institution. For many of the young people that we follow here through the epilepsy program, there are some treatments like nighttime diazepam where we can sometimes assess the first night effect in the EEG lab, but then we'll often circle back and recheck things after a couple months. There are also some other treatments that are used in addition to that, including pulse steroids and intravenous immune globulin and sometimes some other medications. Again, sometimes we will recheck if somebody has a very severe problem or clearly has symptoms. Sometimes the follow-up sleep EEGs are as often as every couple months. Sometimes if the problem is milder or things are more stable, not everybody may need nighttime EEGs that often. And as you may have seen for your son, you know, a full night EEG can be a major investment of time and effort.
Thank you. That was very helpful.
Okay.
Other questions?
My daughter just finished actually a 6-month prednisone treatment for her ESES, and it resolves the issue, and I'm thanking God for that one. But we are wondering, too, along the lines of the sleep, the steroid kind of affected her sleep, so she went on to melatonin. But now, following the tapering off of that steroid, when do I need to discuss kind of lowering her melatonin amount? How do I know what to look for in relation to side effects, long-term, that kind of thing?
Well, again, that depends on the influences for the insomnia. So it's a little bit challenging to make a blanket recommendation. Whenever possible, you know, we think it makes sense to try and use the least amount of medicine necessary for sleep. And even if a medicine is helpful, to try and periodically try and wean off of it to see is it possible to wean from that. And certainly it's good to hear if things have been going well, you've successfully weaned from prednisone and such, that's a good thing. But if the insomnia is still problematic, it may be appropriate to try and delve into why is she having the insomnia, what factors are influencing it, and that would help dictate are there other medical causes or behavioral or developmental causes for the insomnia, where there might be alternative treatment options that would help her get off the melatonin.
Does anxiety play into that?
Very commonly.
Okay, thank you.
Okay, we've got about 5 minutes left. Any other questions?
Hi, my name is Renee Roederer, and I am a chaplain for students at the University of Michigan. And as we know, students, you've already mentioned teenagers today, but young adults often forego sleep for studying or perhaps dealing with the pressures of academic life. And I was wondering if you could tell us a little bit about how lack of sleep might create a risk for a single seizure, perhaps in folks who do not have, regular ongoing epilepsy.
Well, a single night without sleep probably doesn't carry substantial risk for a single seizure unless there's something else at play, meaning another predisposing factor. But it certainly isn't a good thing at so many levels. And it was interesting, you know, just with the population of students that you work with. There has been some sleep research on college students in looking at the impact of one night of total sleep deprivation, staying up for 24 hours. And they tested these college students for cognitive tasks. And what was found was that the college students who were sleep deprived for 24 hours, total all-nighter, they performed worse on the daytime cognitive and learning testing, but their perception was they actually functioned better and such. So they didn't recognize how impaired they were. So again, I think thankfully the risk of an all-nighter causing a single seizure is pretty low unless there's something else predisposing. But where we're most concerned is just the impact on learning and performance and daytime function. That's where it takes a hit, but people don't recognize how much they're impacted by it.
Thank you.
Okay. Other questions? Okay. While people are thinking, I do have one question. With the two latest models of the vagus nerve stimulator include a feature that will start a slightly higher level of stimulation, similar to the magnet use, when there's a sudden increase in heart rate detected. Is there any anecdotal information from your patients or any research that's been done to demonstrate or to suggest that maybe that is of particular benefit for nocturnal seizures, because someone, you know, would not likely be able to use the magnet during nighttime?
Well, these models theoretically have the advantage of being activated automatically, so it doesn't require another person or parent or bed partner to apply the magnet. There's not too much available in the way of formal research for sleep-related epilepsy, and at least at this point, most of the young people I follow with the vagus nerve stimulator, they haven't been upgraded to the newer model yet, but I would have a lot of feedback based on my own patients. Okay.
Okay. I've got about 1 or 2 more minutes for any remaining questions. Anyone else have a question? Okay, well, we will go ahead and wrap it up, and I want to thank you, Dr. Hoban, for such a comprehensive and fascinating discussion of sleep and epilepsy, and thank you all for listening and for your great questions as well. This will be recorded, so people can go back and listen to it once it's been uploaded to our website and YouTube channel. And then if anyone has any questions, please do contact us at 1-800-377-6226 or visit our website at epilepsymichigan.org. And the final call for this year on December 5th is on childhood epilepsy syndromes. Also, I just want to remind everyone that on November 10th we have our Wellness and Epilepsy Conference, which is another great opportunity to learn. So thank you, everyone, and thanks again, Dr. Hoban, for a really great discussion.
Okay, thank you, Russ.
All right, bye-bye.
Thank you.
Thank you. Bye-bye.
Bye now.